Welcome to Mayo Medical Laboratories Video Hot Topics. These presentations provide short discussion of current topics and may be helpful to you in your practice. You may access a handout of this presentation to make notes while viewing this video hot topic. Closed captioning is available by selecting the CC box in the lower right corner of the presentation window. At the end of this presentation, you will be taken to a brief survey. We appreciate any comments or suggestions of future hot topics that you may have. If you have any questions, please email us at mmlhottopics@mayo.edu. Our speaker for this program is Dr. Amy Saenger, Director of the Cardiovascular Laboratory in the Department of Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. Dr. Saenger will discuss the limited utility of testing for erythrocyte folate in the age of folic acid supplementation. She will also offer alternative choices for the diagnosis of folate and vitamin B12 deficiency. Thank you, Dr. Saenger.
Thank you for the introduction. Today I will be discussing utilization of red cell folate testing in light of widespread mandated folic acid supplementation. This is a subject that has received much attention lately due to the discontinuation of erythrocyte folate testing at Mayo. However, I will present data supporting the fact that modern-day folate deficiency is in fact a rare clinical encounter. With that, let's get started. I have nothing to disclose. Folate is a water-soluble B vitamin that is essential for adequate health. Folate, along with vitamin B12, is essential for DNA synthesis, repair, and methylation. Folate coenzymes are also integral in reactions involving 1-carbon metabolism, and although there are various forms of methylated folate in the body, the primary form is 5-methyltetrahydrofolate. 5-methyltetrahydrofolate is also a co-substrate required by methionine synthase for the conversion and demethylation of homocysteine to methionine. Therefore, in the setting of folate deficiency, there will be an accumulation of homocysteine. Folate and vitamin B12, or cobalamin, metabolism are linked by the reaction that transfers a methyl group from 5-methyltetrahydrofolate to B12. Homocysteine, along with methylmalonic acid, will also be elevated in the setting of B12 deficiency, and a combination of MMA and homocysteine has been proposed by some to distinguish between B12 and folate deficiency. Folate deficiency manifests clinically in a variety of ways. Notably, it is strongly linked to an increased risk of neural tube defects, and several observational and controlled trials have demonstrated that neural tube defects are significantly reduced with periconceptual folic acid supplementation. Individuals with folate deficiency may present clinically with unexplained, nonspecific neurological symptoms, including dementia, weakness, and headaches. Folate and vitamin B12 deficiencies are both associated with a reduction in hemoglobin and megaloblastic changes in the bone marrow or other tissues. Megaloblastic anemia is the primary manifestation of folate deficiency, where erythrocytes become abnormally large and nucleated due to the lack of folate necessary for DNA synthesis and cell division. Recognition of the significant relationship between folate and neural tube defects, cancer, and cardiovascular disease led to FDA-mandated fortification of breads, cereals, flours, pasta, and other grain products. Complete fortification was fully implemented in the United States in 1998 with the primary goal of reduction of neural tube defects. Overall, fortification has been successful, and the prevalence of low serum folate among women of childbearing age declined from 20.6% in 1988 to 1994 to 0.8% in 2005 to 2006. The incidence of neural tube defects was reduced by 36% from 1995 to 2006 in the United States. The term folate is utilized when referring to the naturally occurring forms of folate, while folic acid refers to forms used in food and drink supplementation. Folate is found naturally in raw leafy vegetables, citrus fruits, dried beans, and peas. Widespread fortification of foods with folic acid makes it difficult to not have adequate folate status. Breakfast cereals and pasta are routinely consumed foods in the United States and have some of the highest fortification concentrations, as noted by the starred items in this table. There are a variety of clinical conditions that contribute to folate or folic acid deficiency. A deficiency of folate may occur in situations where there is increased demand for folate, such as during pregnancy, lactation, infancy, malignancy, where there is increased cell turnover, infection due to an immunoproliferative response, or chronic hemolytic anemia due to increased hematopoiesis. Clinical conditions associated with malabsorption, such as celiac disease, also place patients at higher risk for folate deficiency. Metabolism of folate may also be impaired due to various folic acid antagonist drugs, and patients with severe liver or kidney disease may have increased excretion of folate. Furthermore, despite widespread fortification of foods with folic acid, deficiency still occurs in situations where there is inadequate ingestion or poor nutrition. High-risk patient populations include people with alcoholism, patients with psychiatric morbidities, and the elderly. Suspicion of folate deficiency may originate if patient history reveals any clinical conditions previously mentioned and/or from results from a routine complete blood count where a low hemoglobin and high MCV are observed. Use of the MCV alone is a nonspecific indicator when used by itself, as patients with concurrent iron and folate deficiency will not have the characteristic macrocytosis seen in folate deficiency alone. Laboratory diagnosis of folate deficiency further includes measurement of serum folate and, less often, red blood cell or RBC, or also called erythrocyte folate. In blood, 95% of the folate is within the erythrocytes. Folate is taken up only by the developing erythrocyte, therefore RBC folate has historically been regarded as the better indicator of long-term folate storage. Serum folate concentrations reflect recent dietary intake of folate, but measurements need to be conducted after the patient fasts. Thus, theoretically, while RBC folate is less susceptible to rapid changes in dietary intake, analytically the assays are plagued with imprecision issues. As mentioned previously, homocysteine and methylmalonic acid may also be utilized to distinguish between folate and B12 deficiency. One critical point to remember prior to initiation of folic acid supplementation is to rule out cobalamin or vitamin B12 deficiency. Unlike dietary folate, synthetic folic acid, or pteroglutamic acid, is reduced directly to tetrahydrofolate without the need for cobalamin as a cofactor. For this reason, the administration of supplemental amounts of folic acid to a B12 deficient patient may correct the megaloblastic hematologic changes, but still allow neurologic disease to progress. This damage is often irreversible. There are a number of methods which can be utilized to quantitate serum or red cell folate. These include microbiologic assays, competitive protein binding assays, or chromatography. A majority of laboratories, including Mayo, use a protein binding assay with chemiluminescent detection for both serum and red blood cell folate, where the red cell hemolyzate is prepared by lysing with ascorbic acid, which releases the intracellular folate, again primarily in the 5-tetrahydrofolate form. There are notable differences between results obtained for red cell and serum folate assays between manufacturers, which is not an uncommon occurrence for any unstandardized assay on the market. Bias between test methods and platforms may be as low as 10% and as high as 70%, despite similar claims of traceability, and occurs throughout the analytical range of the assays. Therefore, there is currently no one standard for folate measurement, and values can vary significantly from one laboratory to the next because of method differences. Analytical imprecision is notably worse with red cell folate assays compared to serum folate assays. This has been well documented in the literature and noticeable in proficiency testing surveys, where the variability even within the same peer group may be up to 50%. Manual sample preparation and variability among procedures to completely lyse the red blood cells are likely responsible for much of this variation. In addition to the documented analytical variables and assay quality issues, Over the last decade, there has been a growing body of literature demonstrating the equivalence of red cell and serum folate testing in an effort to improve test utilization and reduce unnecessary spending. Results from our laboratory and other studies suggest that American populations have indeed attained adequate concentrations of folate, and that modern folate deficiency has essentially been eliminated. This graph shows results from Mayo Clinic patients in Rochester, Minnesota only, who had serum folate ordered over the last 2 years. Of the 24,177 serum folates performed, only 0.5% were less than 3.0 nanograms per milliliter, which is the deficient concentration as defined by NHANES and the CDC. Therefore, a huge majority of samples are being tested that are truly normal. There are not many other routine laboratory tests that have this type of distribution. Normally, a more Gaussian distribution of results can be observed. We further undertook a 10-year retrospective analysis of red blood cell and serum folate results to examine ordering patterns and evaluate the clinical utility of red blood cell folate in our patient population. Results were retrieved from all serum and red blood cell folate tests from the Laboratory Information System at Mayo, ordered on inpatients and outpatients between 1999 to 2009. Data for patients who had simultaneous orders for serum and red cell folate were analyzed, and chart reviews were conducted on those patients with normal serum folate but low RBC folate. These are the individuals who have the potential for misdiagnosis if screened with the serum folate alone. Abnormal values were defined twofold. First, by our current reference ranges, less than 268 nanograms per milliliter, indicating red cell folate deficiency, and less than 4.0 nanograms per milliliter, indicating serum folate deficiency, and by the NHANES CDC criteria for folate deficiency, which are a serum folate less than 3.0 nanograms per milliliter and a red blood cell folate less than 140 nanograms per milliliter. A total of 152,166 serum and 15,708 red blood cell folate assays were performed over the decade. The prevalence of folate deficiency using only serum folate was 0.39% and 0.27% when using only RBC folate. There were 1,082 patients in which serum and RBC folate were ordered concurrently, which is shown in the table. Looking at the abnormal subset defined by our traditional reference ranges, or the top table, you can see that only 39 individuals had a normal serum folate but abnormal red cell folate. 28 of the 39 actually had a normal red cell folate based on the reference range utilized at the time this assay was performed, and therefore would have not been flagged as low. 3 patients were documented as non-fasting, leading to inaccurate serum folate results. 5 patients were on the borderline of low and could be accounted for based on the imprecision of the assay, and 3 were considered to be difficult interpretations, where there was no explanation for the low red cell folate. Using more traditional cutoffs, we evaluated the same set of patients, as seen in the bottom table. In this analysis, only one individual, or 0.09% of the total, had both an abnormal serum and red cell folate using traditional definitions for deficiency. Only 4 individuals had a normal serum folate but abnormal red cell folate, one of which was non-fasting, and the same 3 difficult interpretations as noted above. The following summarizes those 4 chart reviews specifically. The first was a 6-year-old male with a known genetic folic acid transporter deficiency who was treated with leucovorin. The second was a 58-year-old male with a history of gout, hypertension, psoriasis, and hyperlipidemia with a normal hemoglobin and MCV. The third was a 65-year-old male with chronic diarrhea and suspected alcohol abuse, and he also had slight macrocytosis with an MCV of 100.3 femtoliters, but a normal hemoglobin. And the last was a 51-year-old male with multifactorial gait disorder and alcohol abuse. There was a previous history of vitamin B12 deficiency in this last individual, but B12 levels were normal at this time. The CBC was notable for macrocytosis with the MCV of 115.1 femtoliters without anemia. Folate supplementation was initiated only in the last patient. True folate deficiency in the current era of FDA-mandated folic acid supplementation is exceedingly rare. There is no evidence to support routine ordering of RBC or serum folate, but serum folate concentrations provide equivalent clinical information to RBC folate in the assessment and diagnosis of folate deficiency. Based on these statistics, and because serum folate provides equivocal results to red cell folate in almost all clinical scenarios, routine ordering of red cell folate is no longer warranted. Furthermore, investigation of megaloblastic anemia should preferentially be initiated with vitamin B12 testing instead of folate due to the low incidence of modern folate deficiency. In the absence of B12 deficiency, it is more cost-effective to simply supplement with folic acid rather than routinely test and monitor a patient's folate status, similar to other nutritional deficiencies such as vitamin D. Furthermore, discontinuation of red cell folate testing at the Mayo Clinic has been endorsed by several clinical groups and our colleagues here, including hematology, gastroenterology, and endocrinology.